Hello viewers, I am Dr. Rabiul. I work as a lecturer in pathology in a medical college hospital, and I am making this video for my students and also for you. Hope someone finds this helpful. Today's topic is on neonatal respiratory distress syndrome. This video will contain introduction to this disease, followed by brief discussion about its cause and risk factors, and since surfactant deficiency is the cause of this disease, so we will also talk about the role of surfactant, followed by brief discussion about the pathogenesis, morphology, clinical features, diagnosis and treatment of this disease. Okay, so a lot of topics, so let's begin. So first we will talk about some introductory points regarding this disease. And the first thing that you have to remember is that neonatal respiratory distress syndrome is the most common cause of respiratory distress among neonates. Now, what do we mean by neonates? Neonates are newborn babies who are less than 4 weeks old. The second thing that you have to remember is that this disease is also known as hyaline membrane disease. Now, why do we call it in such name? That's because in this disease there is deposition of proteinaceous hyaline material in the alveoli, and that impairs gas exchange, as we will see. So that's why it is also called hyaline membrane disease. The third thing that you have to remember is that this disease is commonly seen in preterm babies, and especially if the baby is less than 28 weeks old at the time of birth, there is high possibility of development of this disease. 60% of the infants who are born at the age of less than 28 weeks develop this disease. So now that we have talked about the introductory points regarding this disease, now we will move on and talk about the cause of this disease. And the cause is immaturity of the lungs. And that's why it is common among preterm babies. But one thing you have to remember that although this is very common among preterm babies, sometimes it can also happen in full-term babies as well. But the most common incidence occurs in the preterm babies. And in your textbook you will see that if the gestational age of the baby at the time of birth was less than 28 weeks, 60% of such infants can develop this disease. And if the gestational age of the baby at the time of birth was between 28 weeks to 34 weeks, then 30% of such infants can develop this disease. And interestingly, the incidence reduces to less than 5% when the gestational age of the infant is more than 34 weeks. And one reason is that surfactant production or surfactant synthesis accelerates rapidly after 35 weeks of gestation. So after 34 or 35 weeks of gestation, surfactant level will be sufficient to counter this disease. So now let's talk about some risk factors that are associated with this disease, and one such risk factor is maternal diabetes. Now let me explain. The thing is, if mother has diabetes, there will be high level of glucose in maternal circulation, and that high level of glucose, which is also known as hyperglycemia, increased amount of glucose in the blood, that high level of glucose will also enter into the fetal circulation. Now what will happen next? To counter this high level of blood sugar in the fetal circulation, there will be hyperplasia in the beta cells of the pancreas of the fetus. And why will there be hyperplasia in that particular cell? Because recall that it is the beta cells of the pancreas that are responsible for liberation of insulin. So beta cell of the pancreas of the fetus will synthesize insulin, and that insulin will be liberated into the fetal circulation, and that will result in hyperinsulinemia in the fetal circulation, and that thing will cause decreased production or decreased synthesis of surfactant, and that's why maternal diabetes is a very strong risk factor associated with this disease. Another risk factor is male gender. If the preterm baby is a male baby, then there is more chance of development of this disease. And the reason is, always remember, lung maturation occurs earlier in female fetus compared to a male fetus. So that was the second risk factor, the male gender of the preterm baby. And the third risk factor is cesarean section. And the thing is, we have seen that labor can increase synthesis of surfactant, and whenever the baby is preterm and the baby was born by cesarean section, that thing won't happen. Okay, so there won't be any labor, and that will not result in increased surfactant production, and that's why in cesarean section there can be risk of development of this disease as well. So now that we have talked about the cause and risk factor of neonatal respiratory distress syndrome, now we will move on and talk about the role of surfactant, because recall that this disease is actually happening as a result of lung immaturity and decreased surfactant synthesis. So what is surfactant? To explain surfactant, you can see that I have drawn an image of alveoli in the corner of the board. So this is an alveoli that is seen inside the lungs. This is a very diagrammatic image. You can see that the walls of the alveoli are lined by two types of pneumocyte. We can see type 1 pneumocyte. These are flattened epithelial cell, and it is obvious, in order to exchange gas, the lining epithelium has to be very thin and flat, and that is the type 1 pneumocyte's nature. And also notice that we also can see another type of pneumocyte here, and that is type 2 pneumocyte. And surfactant is synthesized, stored and released from this type 2 pneumocyte. And you can also see that we are seeing alveolar macrophages inside the alveoli as well. So type 2 pneumocyte will release surfactant, and the main function of surfactant is to reduce the surface tension of the alveoli. And in your exam, the examiners are very fond of asking the composition of surfactant. The major component of surfactant is Dipalmitoyl Phosphatidylcholine. It will also contain smaller amounts of phosphatidylglycerol and also some surfactant associated proteins. Now these surfactant associated proteins are again subdivided into two groups. One group is hydrophilic in nature, and there we will have surfactant associated proteins like SPA and SPD, and they have role in innate immunity. The other group of surfactant associated proteins are hydrophobic in nature, and there we will have SPB and SPC, and they will have role in reducing the surface tension of the alveoli. Now, why do we need to reduce the surface tension of the alveoli? The reason is surfactant, by reducing the surface tension of the lung alveoli, prevents collapse of the lung alveoli at the end of every expiration. Now always remember, at the time of birth, when the baby is breathing for the very first time, the baby requires high inspiratory pressure to expand the lungs for the very first time. Now after that, under normal condition, when there is sufficient amount of surfactant present in the lung alveoli, the lungs will not collapse at the end of expiration, and as a matter of fact, up to 40% residual air volume will be retained at the end of expiration. And this thing will have an advantage, since the lungs is not collapsed at the end of expiration. So under normal condition, the baby will not require high inspiratory pressure in the subsequent breathing, and the baby will breathe with less effort during the subsequent breathing. But what will happen to the baby who is suffering from hyaline membrane disease or this neonatal respiratory distress syndrome? Due to lack of surfactant or deficiency of surfactant in the lung alveoli, the surface tension of the lung alveoli will be high, and therefore the lung alveoli will collapse at the end of every expiration. So in this case, the baby has to exert high inspiratory pressure not only for the very first time when the baby began to breathe, but also in every subsequent breathing. That means every subsequent breathing of this baby will also require the extra effort that was needed for the very first breathing. And that is the problem with this disease. So now that we have talked about the role of surfactant in this disease, now we will move on and talk about the pathogenesis of this disease. And in order to do that, you can see that I have drawn a flowchart in the whiteboard. Okay, I hope you're still with me. You didn't run away just like my students do when I try to teach them flowcharts of pathology. I even have to show them teddy bear to keep them calm. So look, I am also showing you a teddy. So look at the teddy, don't run away, because I will try to explain this flowchart line by line now. Okay, so in this flowchart we can see that everything is beginning due to prematurity of the lungs. Okay, usually the baby is preterm and usually less than 34 weeks old, and as a result of premature lung, so there is decreased surfactant synthesis, storage and release, and therefore there will be less amount of surfactant present in the alveolar surface. So you can see that first there was prematurity that led to decreased surfactant synthesis, storage and release, and therefore on the surface of the alveoli we are having less surfactant, and that will result in increased alveolar surface tension, and so at the end of every expiration the alveoli will collapse, and collapse of the lung alveoli, that is denoted here as atelectasis, that is the collapse of lungs. Okay, so what will happen next? Since now the alveoli of the lungs are collapsed, so there will be problem with ventilation, and also there will be uneven perfusion, and all these things will result in two conditions. So since there is problem with ventilation, so carbon dioxide is retained in the collapsed alveoli and also in the blood, and that cannot be excreted, and as a result of that there is carbon dioxide retention, and acidosis. And also there will be hypoxemia, reduced amount of oxygen in the blood. And all these things are happening due to hypoventilation and uneven perfusion as a result of atelectasis or collapse. So what will happen next? So we have already said that there will be respiratory acidosis due to retention of carbon dioxide, and that will result in pulmonary vasoconstriction. The vasculature of the lungs will begin to constrict. So this thing will lead to further pulmonary hypoperfusion, and since now we have reduced blood supply in the lungs, so now there will be damage, further damage. So now there will be injury in the epithelial cells that were lining the alveoli, and also there will be injury to the endothelial cells of the blood vessels surrounding the alveoli. Ultimately, what will happen? There will be leakage of plasma from the blood vessel, from the damaged blood vessel to the alveoli. And also recall that in the alveoli, the epithelial cells are also damaged, and many of them have died and became necrotic material. So all these things, these necrotic cell along with fibrin, all these things will result in formation of a very special type of membrane that is known as hyaline membrane, and this thing will hamper gas exchange between the alveoli and the blood vessels, and ultimately all these things will result in this respiratory distress syndrome. And one thing you have to remember, that hypoxemia directly can also decrease synthesis of surfactant. So you can see the arrow here, that from hypoxemia we can also go to here. So the cycle will continue, and the condition will become further and further difficult. So now that we have talked about the pathogenesis, now we will move on and talk about the morphology of this disease. On gross examination, the lungs are solid, airless and reddish purple in color, and in your textbook you will see a line denoting that lungs will have color similar to the color of liver in this case. Now what will we see morphologically under the microscope? Under the microscope we will see poorly developed alveoli, and that is obvious because recall that this disease occurs due to prematurity of the lungs. So we will see poorly developed alveoli and they will be collapsed. And also we will see the characteristic eosinophilic hyaline membrane under microscope, and this eosinophilic hyaline membrane will be seen lining the respiratory bronchioles, alveolar duct and alveoli. And we will also see necrotic cell debris incorporating within this membrane. So the examiners are very fond of asking you the composition of this eosinophilic hyaline membrane, and then your answer will be fibrin and necrotic cell debris. And one thing you have to remember, the majority of the necrotic cell debris are derived from type 2 pneumocyte. And also we will see neutrophilic infiltration associated with this hyaline membrane. So now that we have talked about the morphology of this disease, now we will move on and talk about the clinical features. Clinical features will include tachypnea, that is increase in the respiratory rate of the affected baby. There will be also nasal flaring, that is the nostrils will widen during the respiratory process, and this will indicate that the baby is having difficulty with respiration and is requiring more effort during the respiration. Recall that in this disease the baby requires high inspiratory pressure not only for the very first breathing but also for every subsequent breathing. So that's why there will be also nasal flaring. Another clinical feature will be expiratory grunting, and this will happen due to partial closure of the glottis. There will be presence of cyanosis. Recall that cyanosis is the bluish discoloration of the skin and mucous membrane due to low oxygen saturation. And we have seen that here we will have hypoxemia, reduced amount of oxygen in the blood, and ultimately there will be low oxygen saturation, and that will lead to cyanosis. Other clinical features will include intercostal and subcostal retraction, and in extremely immature neonates there can be also apnea. Now, what is apnea? Apnea is temporary cessation of breathing, and that can be seen particularly if the neonate was extremely immature. So these were in short the clinical features of this disease, and now we will move on to the next point and talk about the diagnosis. So diagnosis will be done on the basis of clinical feature, chest radiograph, arterial blood gas analysis, and also by measuring the lecithin sphingomyelin ratio. So we have already talked about the clinical features, and whenever we see such presentation in a premature or preterm baby, it will give us hints that it may be a neonatal respiratory distress syndrome. Now, regarding the chest radiograph, what will we see there? In the chest X-ray, we will have uniform reticulogranular densities and ground glass appearance, and also there will be features of atelectasis or collapse of the lungs. Now, besides chest X-ray, we will also do arterial blood gas analysis, and there we will see acidosis. So the major finding here will be acidosis. Recall that retention of carbon dioxide will result in respiratory acidosis, but here we will also have metabolic acidosis too, because what will happen is, due to lack of oxygen, anaerobic metabolism will begin, and as a result there will be production of lactic acid, and that will lead to lactic acidosis, that is metabolic acidosis. So just remember that in arterial blood gas analysis we will have features of respiratory acidosis as well as metabolic acidosis too. Moving on to the next diagnostic tool, and that is the lecithin sphingomyelin ratio, and this is in fact fetal lung maturation test. It is done by obtaining the amniotic fluid by a process known as amniocentesis, and then measuring the ratio of lecithin and sphingomyelin in that fluid. Now, if the ratio is more than 2, that indicates that the lung is mature, and whenever the ratio is less than 2, that indicates that the lung is still immature. And one thing you have to remember, when the ratio is less than 1.5, there is high risk of development of respiratory distress syndrome. So these were in short regarding the diagnostic tools of this disease, and now we will move on and talk about the treatment of this disease. Initial treatment will include oxygen therapy and nasal continuous positive airway pressure to keep the airways open. The most effective treatment is by administering exogenous surfactant. A lot of preventive measures are now also available. For example, one preventive measure is by administering tocolytics or medications that can prevent preterm labor, and antenatal glucocorticoid therapy can also be started to increase the level of surfactant in the fetal lungs before birth. Now, regarding the oxygen therapy, always remember, whenever we are administering high concentration of oxygen for prolonged period with the help of ventilator, it has some risk. It can result in some complication. One such complication is known as retinopathy of prematurity or retrolental fibroplasia. And another complication is bronchopulmonary dysplasia. So let's talk about these two diseases now. So what is retinopathy of prematurity? The thing is, when we are administering high concentration oxygen for a prolonged period, so during the phase when there is high oxygen in the baby, during that phase the vascular endothelial growth factor expression will be decreased, and as a result the endothelial cells will die via apoptosis. Subsequently, during the next hypoxic phase, during the phase when the therapy is stopped and the baby is now in a relatively hypoxic condition, the vascular endothelial growth factor will again rebound, and that will result in rapid proliferation of the vasculature, and that will result in retinopathy of prematurity. And another complication that we mentioned was bronchopulmonary dysplasia, and here we will see that due to high concentration of oxygen there will be problem in the septation of the alveoli. So as a result the alveoli will appear larger and simplified in nature, and it will also result in dysmorphic capillary configuration. However, all these complications can be prevented by using gentler techniques of ventilation and also by using antenatal glucocorticoid therapy and prophylactic surfactant treatment. So this concludes today's video on neonatal respiratory distress syndrome or hyaline membrane disease. I hope this video was helpful. If you like my videos, do subscribe, share, comment and let me know. And for my students, I will also recommend you to go through your textbooks to know more informations. Okay, so that's all for today. Until next time, take care and stay blessed. Thank you.